Ready to go.
All right, so I've got that. Okay, so I'm going to welcome everybody. Thank you very much for joining us. I'm Lynda Young. I'm the chair of the Women's Caucus at Worcester District Medical Society. And every year we do something in May called the Women in Medicine Leadership Forum. Our caucus, which I'll introduce those members that are with us now, our caucus puts a lot of effort into this and have a lot of great ideas. And this particular topic, basically called Building a Family, is something we have been talking about for almost a year about putting together. And you'll see that the people that are involved in this are going to be talking about fertility and pregnancy in medical trainees and faculty, because this is a concern. Now, this is also kind of in tandem with our magazine, which is Worcester Medicine, which I believe it was the January-February issue, I think, that did exactly this topic. And some of you were very, very involved in that, and thank you for that. So this is what you're going to hear about tonight. And when I turn the program over to Heidi, she'll go over the specifics about asking questions and that sort of thing and introducing people. So that's what we're going to be having. I do have to say that we want to give a big thanks to Physician Insurance. This used to be called PIAM. It is a agency associated and actually in the Worcester District, in Massachusetts Medical Society. Over the years, they have been incredibly generous to us. They continue to be generous in helping funding this. And tonight we do have Megan Stanley with us. I believe Megan is on or will be on. She's the marketing manager from Physician Insurance. So thanks again, shout out to Physicians Insurance for their ongoing support. The other thing that I want to let people know is that we are doing closed caption. And on the bottom of your screen, you will see a little thing that says live transcript. If you wish to see closed captioning, if you click on live transcript and then click on subtitle settings, you will get closed captioning on your screen. So that's something that we haven't done before and somebody had requested. So we are available for that. So without further ado, I would like to introduce the people that are on this call. Here's our Women's Caucus. The Women's Caucus has been around. We were trying to figure out how old we are. And it's been around for, I want to say, close to 30 years. And we started this in the mid-1980s. And we have been continuously active and doing these programs ever since. So these are the people that are in this. And I was going to go through tonight who is on this call, but I don't want to really take the time to do that. So I do thank those of you from the caucus who are very instrumental in putting this together with us and in deciding on all the topics that we discuss. So I'd like to go ahead and introduce the woman that has been instrumental in getting this going, and that's Dr. Heidi Leftwich. So Dr. Leftwich is an assistant professor in the Department of Obstetrics and Gynecology, Division of Maternal Fetal Medicine at UMass. She's board certified in obstetrics and gynecology and maternal fetal medicine. Dr. Leftwich completed her OBGYN residency at the University of Connecticut and her maternal fetal medicine fellowship at the University of Illinois in Chicago. Her clinical practice is focused on caring for those with high-risk pregnancies. In 2018, she became the Associate Fellowship Director of the new Maternal Fetal Medicine Fellowship at UMass Chan Medical School. She is the treasurer of the Worcester Healthy Babies Collaborative, which focuses on decreasing rates of infant mortality and health inequities. As for our Worcester District Medical Society, Heidi's a member of the Scholarship Committee and, of course, the Women's Caucus. So, Heidi, thank you so much for doing this. I'm going to turn this over to you. You can introduce the panel, and Martha's going to be bringing this up. So thank you all for joining us, and as we say, on with the show.
Thank you so much for that lovely introduction. So I have the pleasure of introducing our esteemed panel, but first I just wanted to take a moment for general housekeeping rules. I think this is a little bit smaller than we had expected, but if people join in, it will be bigger. In terms of questions, I think if we could just add them to the chat as we move forward, it would be the easiest, and I will try to moderate at the end. If we have time and our speakers finish a little bit before theirs and you have a speaker specific question, I'll try to look in the chat and ask them kind of at the end of their presentation. Super informal, feel free to do others, but I think that's the way to keep these types of meetings going, and I'm happy to respond directly there. So just to introduce our panelists real quick, because I'd like to get started, Dr. Armando Arroyo attended UCLA School of Medicine in Los Angeles, completed his OBGYN training at the University of Arizona in Tucson, and reproductive endocrine and infertility training at UCSD in San Diego. He then completed his training as a women's reproductive health research scholar at UCSD, where he studied reproductive neuroendocrine system. For the last 10 years, however, he's been working full-time in the IVF field or infertility field as a reproductive endocrinologist, first at CNY Fertility in Syracuse, New York, and then Boston IVF. Dr. Arroyo is currently the medical director at our IVF center at the UMass Memorial Fertility Center, and he's an associate professor at the UMass Chan Medical School. He's board certified in OBGYN and REI. Dr. Jennifer Yates is an associate professor in the Department of Urology at the University of Massachusetts Chan Medical School, where she has practiced for 9 years. She serves as the residency program director, and her practice focuses primarily on renal and bladder cancer. While she has no geographic roots, having been raised in a mobile military family, Dr. Yates calls New England home after completing medical school in St. Louis and residency at Brown University and fellowship at Hackensack University Medical Center. We're very happy to have Dr. Yates with us. And then we have Dr. Christine Van Horn. She is a PGY4 urology resident at the University of Massachusetts Chan Medical School program. She received a BA in molecular and cell biology from UC Berkeley and an MS in biological chemistry from UCLA and her MD degree at the Keck School of Medicine at USC. She's currently applying to endourology and minimally invasive surgical fellowship, surgery fellowship, with a plan to pursue a career in academia. She's very passionate about quality improvement research and advocates for the change within her institution and beyond. Outside of work, she enjoys travel, knitting, and exploring local restaurants. We're really happy to have all three panelists for you today, and I'm going to start us off actually with Dr. Jen Yates, who will start the program. Thank you.
Great. Thank you so much for the introduction. So we're going to start with a little audience response system poll that I believe, Martha, you will be able to execute. And feel free as the audience to answer these questions. We're just interested in getting a little snapshot of our audience today and just to get kind of a basic understanding of knowledge base and where we're coming from as a group. So this is the first question. So it looks like the majority of our attendees fall under the category of medical students and faculty. So it's a constantly influx poll here. All right, can we go to the second question, please? All right, the majority of our attendees today identify as female. Can we have question number 3, please? What age categories do the majority of our attendees fall under here? So we have a great distribution. Fantastic. So this will make for some good questions and good dialogue. Can we move on to the next question, please? Great. So it looks like the majority of us fall into the category of planning to have children or already have children. Can we have the next one, please? All right, and this is relating to the topics we're going to discuss today, just to get an idea of what's on everyone's mind and why you've joined us today. Great, so we will talk a little bit about all of these topics. Unfortunately, with our time constraints, we could probably spend hours on these topics, and in the future maybe can branch off down some rabbit holes and have additional conversations. But we're going to try to cover a couple of these topics today in a little bit of detail. And I'm going to go ahead and share my screen, Martha. Thank you. All right. So let's go ahead and start by defining the problem. Why are we here today? And what are some of the threats to childbearing in training and beyond? And a disclaimer at the beginning is the majority of the content here is directed at trainees or faculty who identify as female, since a lot of the logistics and issues that we face relate to fertility, female fertility issues, and we'll talk about a little bit advanced maternal age, but certainly we'll talk a little bit about advanced paternal age as well. And this problem, this quandary, is absolutely not unique to female trainees and faculty. So there's a lot more exposure in the media these days about the fertility issues that we face as physicians and trainees. And this was a great article that I read when it first came out last year. And you can, if you have a New York Times subscription, you can read it. And I think you're allowed 10 a year. So feel free to Google this and read it. It's a really interesting article, just kind of defining and identifying what we struggle with. And really one of the root causes is just the sheer amount of time that we invest in our training. And then all the other time points that we wait to have children, such as finishing our fellowship, getting established in our practice, so many potential obstacles. So I'm going to go over a little bit of literature and data as quickly as I possibly can. I have a timer running because Christine has a lot of great information she'd like to discuss with you before we turn this over to Dr. Arroyo. So this was a survey that was sent out to female surgeons via an interest group and word of mouth, and there was 1,000 responses, and they compared this to the CDC national survey. And what they found was 30%, let me minimize my reported fertility difficulty. Oops. 76% went on to use assisted reproductive technology, and 33 was the age at first pregnancy that was reported. And this is quite a different number than you would necessarily see when we're comparing this to non-physician pregnancies in this country. And this is just a graph from that article demonstrating the differences that we see as far as the U.S. population in red versus female surgeons. And in a few minutes, I'll show to you that this is not necessarily surgeons that are the ones suffering exclusively from this, but basically all of our colleagues in the House of Medicine. This is another article from 2012, a survey of 850 surgeons compared female surgeons to male surgeons, and they looked at their female partners to kind of to help stratify the demographics and keep it a viable comparison. The female surgeons compared to the female partners of male surgeons had a 42% reported pregnancy loss, compared to male partners had fewer children, were more likely to delay, and more likely to use assisted reproductive technologies and have complications related to pregnancy. So this is a pretty substantial number that we're looking at here as far as pregnancy complications, non-elective C-section delivery, postpartum depression, musculoskeletal disorders, likely multifactorial, but a lot of this could have potentially been traced back to some of the challenges we face just physiologically when we're in training, whether we're in a procedural or non-procedural specialty, and beyond as faculty. This is a pregnancy among women surgeon trends over time. And this was sent out to the female surgeons, predominantly in the ACS. And what we found with this study was the perception of stigma associated with pregnancy was higher in the older cohort of respondents on the survey. But look at how many younger respondents still felt that the persistence of stigma was a reason that they would either potentially avoid pregnancy in their training or strongly consider that before proceeding. So we're looking at all these different factors, delays in childbearing from training standpoint, and then the stigma associated with that, and then the logistics. And Christina will talk a little bit about that too, what we can do going forward to help with the logistics of childbearing and raising children in training. So what about procedural versus non-procedural specialties? This was sent to a survey sent to female physician mothers. And what they found was that of the quarter of them that were in the procedural field, there was a higher rate of assisted reproductive technology utilized for pregnancy, missed work during pregnancy, C-section delivery, and missed work due to preterm labor. Another study in women urologists, of course, these are something near and dear to Christina and I as both urologists. This was sent to board certified female urologists. And they found, again, this is similar trends that we're seeing throughout, 10-time increased risk of needing ART for pregnancy, increased induction rates, pregnancy complications. And more recently, this is a survey sent to female urologists, all ABU diplomats, and they compared this to the 2007 data and found that we're still seeing the similar trends to over a decade ago. Surgeons are having children later in life. Complications did not decrease over time. Infertility was similar to what it had been reported back in 2007. And length of maternity leave correlated
I can't hear anything.
with satisfaction over time. So this is a survey using health belief model looking at residents. So we've just talked a little bit about faculty in procedural and non-procedural specialties. What about our residents? As we all know, they have a pretty burdensome schedule when it comes to call, shift work, and everything that goes along with that as far as logistics of pregnancy and just the physiologic stresses of trying to become pregnant in pregnancy. And there was they were less likely to plan to have children during residency. They perceived a threat to their career as one of the reasons that they decided to delay pregnancy. And in a later study, female residents were concerned about the negative impacts on reputation and career of job demands on their pregnancy and trying to provide a healthy pregnancy for their children. And female residents, not surprising, were expected to be the primary caregiver on weeknights, which is a challenge, as we all know, and require weekday childcare from a non-parent. Nothing surprising here, but just putting this all into kind of hard facts really brings it home to us what we're facing as physicians and trainees. Another resident survey looking at female surgeons who had one or more pregnancy during their general surgery residency program. And they found of those trainees, 85% continued on their usual track of workload without any modification to their schedule, such as changes in call schedule, changes in the length of their day, whether they were on night shift or night float. 63% were concerned that it could affect their health or their baby's health, and 78% had a maternity leave of 6 weeks or less. So there's Christine's going to talk a little bit about some of the national trends and specialty specific trends that are working to address this. But wow, what a burning platform. And this is recent data. This is 2018. So certainly concerning. And same study, more likely to have felt that their maternity leave was inadequate. No surprise, 6 weeks or less. Over half stopped breastfeeding earlier than they had planned, even though the vast majority of them acknowledged that breastfeeding was important to them and to their child's health. And very few, under a quarter, had institutional supportive childcare. And I'm sure many of us have experienced this as well. And again, not surprising, there was a desire for greater mentorship. Again, Christina will talk about this in a few minutes as to what we can do within our specialties and within our House of Medicine to try to improve this. Many seriously considered leaving a surgery residency. And unfortunately, I don't have enough time to present all of the data that we have on this. But there was a study out of Japan and very similar results. They actually faced statistically even more significant rates of bias and sexual harassment based on the fact that they were pregnant in a residency training. So this is not unique to us in this country, really a challenge for physicians everywhere. And the numbers that were quoted in the Japan study, similar, almost over a third of the respondents considered leaving their surgical residency because they had had a child during residency. And about a third would discourage female medical students from a surgical career. Well, that's powerful. Those of us who are surgeons are fairly passionate about our specialty and our career, and to think that a third of us would leave because they don't have the support they need to be a mother and a surgeon is disheartening. So I'm going to change gears a little bit. We've defined the problem. Clearly, we have a burning platform of trainees and faculty facing challenges, whether it be bias during pregnancy or about pregnancy during their training, whether it be the challenges associated with maintaining breastfeeding or the lifestyle that goes along with training and being a physician. But what are some of the other challenges that are unique to us for fertility and childbearing? And I'm keeping that there's a lot of great data out there, and I'm trying to keep this very limited so that we can move on to our next topic. But rest assured that if you would like to read more about this, there's a lot of good literature out there, and the body of literature is expanding. So our biggest threat, unfortunately, is advancing age. And I love this quote by C.S. Lewis: "The future is something which everyone reaches at the rate of 60 minutes an hour, whatever he or she does, whoever he or she is." So I'm sure everyone is guilty of this, especially us physicians and trainees, who are probably the vast majority of us are type A personalities, where we truly believe that the limits of space and time don't apply to us. We can get more accomplished in a period of time than mere mortals can. And this, of course, is not true. And of course, the constraints of time do apply to us as we get older. And somehow it just passes residency, medical school, fellowship in the blink of an eye. And suddenly you're looking at your late 30s and wondering, how did this happen? So the question is, when is the ideal time to start a family? We will not answer that question in today's lecture, because that is a question that I think that the answer is unique to every one of us, and there's no standard answer. I think what's important is having a dialogue about this, discussing our own experiences amongst each other, mentoring to kind of help everybody decide what is the right time for you. But this was a Canadian study looking at physicians and when they initiated childbirth and childbearing. And as expected, based on the other data that I presented, this is usually a much older age than non-physicians. The median age at first birth is 32 versus 27. And as we know, and I'm sure Dr. Arroyo will speak to in a few minutes, the fertility rates significantly decline with time in the 30s. So unfortunately, our prime childbearing and fertility years coincide beautifully with our training years. So this is a dilemma that we can't fix, as the future is something that we all reach at the rate of 60 minutes an hour. So looking at advanced maternal age, and I'll talk a little bit about advanced paternal age, but there was a lot of data early on, and this is looking at not physicians specifically, but just all comers who entered pregnancy later in life. And I think Dr. Leftwich can probably vouch for this, that older mother becoming much more the norm. And maybe I'm saying that selfishly because I was assigned horrific titles like advanced maternal age and geriatric mother. But I think that this is becoming much more common, where delayed childbearing is seen, and there's more data that's being kind of borne out as we study these people. But early data showed that there was a slight elevation in low birth weight infants and a higher rate of complications. And this is, again, non-physicians, just all comers. I'm looking at a Norwegian patient population, and the beauty of this patient population is they capture the data very nicely in the way that their healthcare system is structured. So easy to do data mining for these types of studies. And they found that the risk of miscarriage was lowest in younger patients. Not surprising, begins to rise after age 30. And at age 45, the risk is as high as 53%. So I think that this kind of speaks to that, our belief system that many of us, myself included, thought, don't worry about it. You get older, it's fine. We have assisted reproductive technology. There's so many things we can do to overcome the confines of age and time, but that isn't necessarily true, because we're really fighting physiologically decreased ovarian reserve and all kinds of other problems that I know Dr. Arroyo will speak to. Another study looking at advanced maternal age, pregnancy loss. So advanced maternal age was a strong predictor. Stillbirth, fetal complications as well, including chromosomal abnormalities and fetal growth restriction, preeclampsia, gestational diabetes, and C-section rate increasing. So in addition to adding the stressors that go along with our work schedule, such as night shift and night float and long work hours, now we're looking at just what is inherent to childbearing at a later age. This sounds so depressing, but I think we're going to have some good conversation when Christine presents what we can do advocacy-wise. So please don't lose heart yet. This is not a problem that's unique to U.S. physicians and trainees. This is that article from Japan that I mentioned, where they really face similar problems that we do in this country. Advanced paternal age may also be associated with challenges building a family, including spontaneous conception rate decreasing, obviously not to the same degree that we see with female physicians and trainees. It may negatively impact assisted reproductive technology outcomes, and there's also a high rate of de novo autosomal dominant mutations. So we don't always talk about advanced maternal age. We're so focused on the maternal factors, but certainly that's something to consider in our male trainees and physicians as well. So what about work hours and shift work? Physiologically, those of us who have been through a pregnancy can vouch for the fact that it is a physiologic stressor. And when we add all of the other components of our chosen career, it certainly at times can seem pretty overwhelming. So this was a meta-analysis looking, again, this is not physicians, this is just looking at all workers that were assessed in this study. And rotating shifts was associated with an increased risk of pregnancy complications, longer hours associated with some of these complications. I'm not going to go into great detail for the sake of time. General occupational factors, again, not physicians, just all comers in the world of physical working and the work hours consideration. Physically demanding work such as heavy repetitive lifting and load carrying could be associated with preterm birth and preeclampsia. Prolonged standing could be, interestingly, long work hours, but everybody chuckle to yourself here, more than 39 hours per week. I'm sure all of us put in, as trainees and faculty, a lot more than that. So while long work hours were not associated with preterm birth, it's hard to extrapolate this to exceptionally long work hours that we all probably experience most weeks. This is something that is near and dear to urologists, and I'm sure many of you who are anticipating entering a field such as radiology would also have similar concerns. What about radiation safety? I remember when I was a resident, we worried about this, and we also worried about exposure to inhaled anesthesia, because there's that risk if you're pregnant of potential injury to the fetus. And this is a big one for us because we use a lot of radiation in urology. And oftentimes this is a big problem because we don't declare pregnancy until after the first trimester. It's a very personal decision, and many elect to keep that as a private event until they're comfortable revealing all. So radiation safety is mandatory, but when does that actually begin that we're monitoring the fetus? And I think I'm not going to go into great detail on this because we could talk probably for 20 or 30 minutes about radiation safety and the data surrounding that. But what I want to drive home to our trainees, especially, I think the critical take-home message is you don't need to tell anyone you're pregnant if you're not comfortable doing so, but at a minimum, contact the radiation safety officer at the institution. UMass has a radiation safety office. Let them know it's confidential information. Start getting monitored. Make sure you're using the correct lead. If we wait until we've declared it to our employer, our department, our division, at that point we're already months into a pregnancy, and we've really lost that opportunity to ensure that we're using all of the appropriate measures to protect our fetus. This is one study. There's not a lot of data out there in physicians. There's a lot of data about radiation safety in our pregnant patients. This was a fellow who was a neurointerventionalist, and they probably use a lot more radiation than we urologists do. And the radiation dose to the fetus as measured underneath the apron was negligible. So reassuring. I mean, an N of 1 is not fabulous, but still there's been plenty of validation of the lead and of the measuring of the fetal dose underneath the lead. There's no data that people who are in radiation centric fields will have a higher rate of infertility. Now, of course, this is assuming that we use appropriate lead, et cetera. And most of this data for miscarriage and poor outcomes really comes from nuclear accidents and nuclear events rather than studying it in physicians and trainees. So just important factors to consider when we're talking about radiation pregnancy, trying to minimize the amount of radiation so the amount of beam on time. Distance is important. Wearing the lead, a wraparound lead is critical. Limiting the monthly dose. I'm not going to go into all the granular details of this, but importantly, if you're a trainee or a faculty member and there's any chance you believe you might be pregnant, make sure you're wearing the correct lead. If there's any question, it's called the radiation safety officer. So I'm going to pause there. I think 18 minutes, I'm going to turn it over to Christine so she can take over with discussion of advocacy and what we can do next to really change this landscape that I just introduced. And then we'll turn over to Dr. Arroyo to talk about different fertility components in assisted reproductive technology. Thank you, Christine.
No problem. Give me just a second. I'm going to talk first a little bit about some data that Dr. Yates and I have from a project that we did for the medical students and the residents on the call. You may remember hearing and seeing emails about this survey, so if you filled it out, thank you very much for doing that. So talk a little bit about some of the preliminary data that we have. So to give a little bit of background about this project, as we've already kind of seen and as we know from social media and what's out there, there's more and more non-traditional and female trainees. There's more and more older students starting out in medical school and residency. I myself will admit to being a non-traditional resident, being older than the average person who went straight through. There's more and more women going into medicine, and there are a lot of documented issues within the literature regarding, getting time off for maternity leave, potential pregnancy complications related to being in residency, stigma, and then also there's limited data about how aware trainees and students are of these issues. And the current perspectives on these issues. Some of the data is a little bit older in terms of some of the more negative aspects of this. And we've seen from what Dr. Yates has already shown that there are some significant issues in terms of how this is all handled. And we wanted to get a sense of how things are currently at our institution and sort of in the modern age, in the post-COVID era, or in the peri-COVID era, as it were. So we did an IRB-approved survey-based study. It was adapted from previous work that Dr. Davids had done with faculty, if I remember correctly. And we distributed it to medical students, residents, and fellows here at UMass over September of 2021. We added in some additional questions beyond the basic demographic and childbearing planning questions, and expanded it into knowledge of what is currently available in literature in terms of some of the issues surrounding having children in training, as well as knowledge of cryopreservation. And then we looked at all the study data in REDCap. And so here's some beginning of some of our data. Some of the key things that the majority of respondents, this is all the preliminary data, by the way, the majority of respondents were residents. We had about 8% of the pool was medical students, and about 12 that had responded. Now I think we have about 60 or 70 in the final data set, which is very exciting to get more of their perspectives. Most of the residents who responded were in their first through third years of training, I think, which corresponds to the fact that internal medicine is one of the largest, if not the largest department in the hospital, and it's a 3-year program. There were some fellows and further along trainees that also responded, and the majority of trainees were internal medicine, though there were a lot of surgical and procedural residents who also responded when you cluster them together. So that's all the surgical subspecialties, general surgery, anesthesia, etc. And then these two particular data points really stuck out to me when I was looking at the data, which is that most residents don't believe that their decision on what specialty to train in was influenced by their considerations for when they wanted to have children or if they wanted to have children in training, which is good. And then also most of the residents said that their programs were supportive of them having children in training, which is also good news, especially with some of the historical stigmas that are associated, especially in surgical fields. What was a little bit more concerning was, and I don't have the data here in a figure, but a lot of residents still felt guilty about having children in training, which I think is an issue that we need to address. But also in terms of what you can see here on this slide, these were a series of true-false questions that were asked in the survey. And the majority of the answers for some of these, people were unsure about what the answer was. Some of these, the majority got them right. For example, the basic question about stigma, a lot of the questions that had to do with negative attitudes, generally people got correct, which I think was sometimes based out of knowledge, but sometimes also based just about the general pessimism some of us have. But for some of the other ones, people just weren't sure. And so I think, and the same thing went for the cryopreservation questions. People just weren't sure about what the answers were, how much things cost, the logistics of it. And it highlights a knowledge gap that we can potentially address. So in terms of our preliminary data, we could see that residents are unfamiliar with what's out there in the literature in terms of issues of having children in training. The respondents were young. Most of them were under the age of 30. But they were concerned about their future fertility. Most of the departments with respondents were seen as supportive. The respondents, as I said, still felt guilt about having children in training. And in terms of future directions, we are hoping to do a lot with this. We're hoping to not only analyze the full data set now that we have more medical student respondents and more residents, but also turn this into an intervention at the undergraduate and graduate medical education level. to start to address some of these issues at an institutional level. There have already been some good things done at UMass. There's I'm not sure exactly how to describe it, but Dr. DeMarco has talked a lot about how certain departments have money that they'll pay into pools. So if somebody covers call for a trainee who's pregnant, that money either gets paid out to the resident, or I think in general surgery, they have a pool that money goes into that the residents then use to do like activities. So there's ways to try to make it that people don't feel as guilty about using something that they have every right to use, which is their time off to have kids. And so I think there's a lot that we can potentially do with this. And there's already been some buzz at one of the other research symposia about trying to take this back to junior faculty and doing other things like that. So if anyone has any suggestions about where we can sort of take this and where else we can explore and get more data, we'd love to hear it. And then sort of shifting gears a little bit, these are my references. We'll talk a little bit about the advocacy piece, as Dr. Yates had alluded to. So essentially today's talk, I think for all of us, is a call to action, sort of a chance to really highlight this issue and then, potentially bring something back, make some changes either at our level or, if we have grander aspirations or more connections, at a larger regional, national sort of level. So I think that overall, this is a complex issue that has a lot of potential ways to address it. There's the national advocacy piece, there's individual advocacy, culture shifts overall within medicine as a field, and mentoring. And the important thing is that this needs to be addressed for multiple phases of one's career. So it's not just, helping medical students understand the issue and how to prepare for it. It's about helping trainees in the thick of it, helping junior faculty in the thick of it, to make sure that, every phase gets the support that it needs. So in terms of national advocacy, the American Medical Women's Association has done a ton within this realm. They have their Physician Infertility Initiative. They've had a series of lectures, panels. They do advocacy at the national level. There's a lot of work that they're doing that you should definitely check out. And that's sort of highlighting one of the biggest pieces out there. ACOG has also done a lot in terms of policy statements in the area of parental leave to try to push for national change. And I apologize if this seems very quick. I had double the slides before and I was trying to make sure I stayed within time. In terms of individual efforts, I think the biggest thing is empowerment that we can give to trainees and to junior faculty. So, and also just destigmatizing some of this through these individual efforts. So having it within curricula, having it within orientations, having information for local resources for these kinds of issues in fertility management available to trainees, readily identifiable and accessible. And then also having education for final year trainees on how to negotiate contracts and discuss requesting paid leave for parental leave, because I think that's a big piece that we don't necessarily talk a lot about, like the business of medicine is sort of like the, quote unquote, like handshake, dirty sort of aspects of being in a, in a field that's also a business. And I think advocating for trainees to understand that process of their first contract and how to negotiate it, but also like that they should advocate for themselves. And then asking for those things is not unreasonable. I think that's a really important piece because no one wants to like end up with a bad contract for their first job, and potentially shortchange themselves in these issues. In terms of culture shifts, I think we've touched a little bit on some of this already. But cultures in medicine definitely have to shift. We need to be able to support trainees at the institutional and the national level. We need to make sure that there's equitable access to fertility care. And we need to remove the stigma around pregnancy and fertility and all in between. And that's because it has a lot of potential benefits in doing so. And we can help trainees and junior faculty not have to defer family planning. Because as we've seen, the data supports that trainees don't want to be a burden on other people. They want to, they want to learn, they want to become the best doctors they can be. And they're holding off on being people as a result of that. And then there's a way to have a balance. The goal also can be to encourage more trainees to consider medicine, because in some ways medicine is considered a field where you sacrifice yourself. And that's true, and it's an important part of it, but also there's a balance. And then also reducing the culture of shame and guilt around family planning and infertility, because I feel like it's seen a lot of times as a personal failing when it's not. It's just biology. It's a disease like any other disease. And I think the stories that I've heard in the process of doing all this research have been so enlightening. And, I feel like we need to have more of those conversations, which is why I'm so happy we're having what we're doing tonight. So things to consider that we can all take back with us is, how do people pay back call after parental leave? I've talked a little bit about what UMass is doing on that front. Is there equal parental leave for both genders? Do, male spouses and partners, get to take time off when their spouses have kids? How are residents encouraged to support their colleagues who are on leave? If a trainee or new faculty member is hired and pregnant, how are they accommodated within the group? And then what's already happening, just a little bit of a teaser of it, is that some of the things are changing within medicine. So there have been changes to the policies in terms of leave, and how it impacts board eligibility, because that has always been an issue. And then there have been cultural shifts in individual institutions, which we've talked a little bit about in terms of UMass. So ABS and the ABU have all changed their family leave policies to be in line with what the ABMS has instituted. And I think this is really huge, because I think a lot of times people talking about surgery, it's too hardcore, it's too intense, you can't be a person, you are but a scalpel wielder. And so the fact that now they've changed the leave policies to be more reflective of, people wanting to take time off to do the human thing of having children and be a part of their lives, adopt, and all those things. I think that's a huge movement in the right direction. And so there's a lot of text on here, but they've done a lot of things to try to accommodate varying ways that this can be handled, extending training, extending chief year, averaging it amongst multiple years to be more flexible. So if, say, somebody has a kid as a PGY2, they don't get completely messed up in terms of their time off. The same for the ABU. We're doing the exact same thing within urology, which I think is also a huge thing. Again, as a surgical subspecialty, the last thing you want to do is, want to do something that you feel like the clock is ticking on it, but also have it be that now you're not board eligible, because that would be a horrifying nightmare after 5 to 6 years of training as a urology resident. So is another huge step in the right direction. And then the last piece, just very quickly, is mentoring, which I think is a really important thing that all of us can do. And it's not really using mentoring in the exact definition, but it's more about just peer support. Mentoring, if you can do it either because of your experiences or your role, but also just being there for others within this community. So having empathy and support, encouraging others to want to advocate for themselves, normalizing this entire discussion is a huge piece of it. Being a resource, and then sharing your experiences. And with the one caveat that everybody's experiences are going to be unique and different. Some people will go through everything very smoothly. Some people will have a ton of setbacks, challenges. So, the important thing is to share those experiences to normalize without potentially leading to inadvertent stigma in the other direction if someone's experience doesn't match yours. But I think this is also a huge piece, because, it takes a village, it takes us all supporting each other to deal with these sorts of issues. So in conclusion, this is a complex, multifaceted issue, requires advocacy and interventions at multiple levels to address it. There's a lot of different ways that we can intervene depending on what specific phase of training you're looking at. And then a lot of changes have come, which is great. But there's a lot of work to still be done. And so hopefully things will keep going in the right direction and keep changing and evolving. And those are my references for that part. Let's stop sharing.
Perfect. Thank you, Dr. Yates and Van Horn. We're going to move forward with Dr. Arroyo.
Okay, there you go. Ready? Can they see me? I think so. Can you see me?
Heidi, you all set?
Yeah?
You should be perfect. We can hear you and see you.
Okay, let's see. Oh, how do I move this? Oh, there it is. Okay, all right. Okay, let's build a family. That's what we do. That's what I do. And so I'm going to just discuss female age-related decline in fertility. And also discuss the effect of maternal age on oocyte quantity and quality, and then a little bit about planned oocyte cryopreservation. Okay, so let's go right to the problem. So as we've heard, fertility rates decrease with increasing age of women. So here's the study with this historical data. These are marital fertility rates for 10 populations with no contraception. And you can see it. You can see it clearly right there, okay? That the fertility rate per 1,000 wives, this was published in 1986, decreases, okay, in the 10 populations. The decline starts at age 30, and then there's a steep decline beginning at age 35. And I'm gonna be talking about age 35 quite a bit. That's going to be kind of the theme here. what age, what's the critical age? And I think from my own experience, and you'll see 35 is the age. And then, as you can see from the graph, fertility ends at 47. So that's fairly clear, yeah. And women who are having children after that, most of them are using donor eggs. Now this little thing here, I just saw a patient, a couple that told me she was 37 years old, and she said, Dr. Arroyo, it's you know what? I had my first 2 children, and I was 30, and it's a breeze. It was a breeze, simple, boom, just happened, no problem. And now I'm 37. And it's become much more difficult. I have 2 miscarriages. I've been trying for 3 years. Nothing is happening. So this is, what I hear, every day. Then we know the decline now, that it's due to a decrease in the egg quantity and the egg quality. Now, we also see this in the IVF population. We do a lot of IVF. In 2018, there were 300,000 IVF cycles performed in the United States, okay? And you can see from age that the live birth rate decreases with advancing age. So just in general here, you can see that for women, and I see this all the time, when women are 35 and under, and they do 1 IVF cycle, approximately 50% of those couples have a baby on the first attempt, 45 or 50%. Okay, when the woman is 37, then that drops to 35%. So there's a 15% drop. When the woman is 40, 39, 40, now you're closer to 20%. And then when you're 42, it's down to 10%. When you're at 42, you're down to 2, 3, 4. And over 42, you're down to 1%. So we see the decline with IVF. Now, we know now that the decline is due to a decrease in the number of eggs. And you can see now the models here, 3 different models of age and quantity of eggs. And you can see, the first one here is kind of a straight line, a straight decline. Here, there's a little bit of a curve. And here, there's a greater decrease around age 35 again, age 35. This model here is a newer model, but you can see here at age 0, when you're born, women are born, they have approximately 500,000 eggs, okay? And then there's a decline that is occurring, and then around age 35, you're down to 10,000 eggs from 500,000 eggs, and then at age 50, you're down to 1,000 eggs. So this is normal. Now, but there's another factor. It's not only the quantity of the eggs, but also the quality of the eggs. And we see this, so more of the eggs are losing their function with advancing age. And this is the Norwegian study that was referred to earlier, and they followed 421,000 pregnancies, and this was 2019. But you can see that the miscarriage rate when you're in 25, 27, it's lower, 10%. And then as 35, that's when you start seeing the increase. And then when you're up to 45, now the miscarriage rate is close to 60, 70%. So here we're starting to see a different factor, the quality of the eggs, okay? And here you see it, this is another study, but you see this curve, okay? Age 30, age 50. This is an interesting study. So this is the intrinsic fertility of 1 human oocyte. 1 human oocyte, okay? Because they did 14,000 natural cycle IVF cycles with single embryo transfers, okay, in Japan. So these were natural cycles. Women had a natural cycle. They had 1 follicle. They took the egg out from 1 follicle, and then they made an embryo and transferred that embryo back into the woman. Okay, so you can see that women at age 30, okay, the live birth rate per egg is 0.3. Okay, so one egg is not going to make you a baby when you're 30. It's actually about 0.26. So you need about 4 eggs to make a baby when you're 30. Okay, about 4 eggs to make a baby. Okay, now when you're 42, the rate is 0.1. Okay, so now you need about 10 eggs to make a baby. So there it is. And so now you need 10 eggs. When you were 30, you needed 3 eggs. So now there's more abnormal eggs at age 40. Okay, so the estimate is that at age 40, the general estimate is that approximately 60% of the eggs have lost their function. Okay, 40% of the eggs are still normal. Okay, now, so what's the quality? We talk a lot about quality. You know, you hear it a lot everywhere. The quality of the egg has reduced. So what is it about the quality? What is the problem with the egg? What's going on? Is it a metabolic issue? Is it a biochemical issue? What is it? Well, right now the #1 factor is oocyte aneuploidy. Okay, so the incidence of aneuploidy increases with maternal age, and you can see it right here. This is the black line right here, and again at age 35, you see the increase in aneuploidy in oocytes. Okay, and okay, it goes up from 10% when you're in your 20s, and then boom, 35. Now it's going to 30, 40, 50, 60, 70, and when you're 45, almost 100% of the eggs are aneuploid. That's why at 45, all the pregnancies, 90% of the pregnancies result in miscarriages. So it's an aneuploidy issue. That's the #1 factor. Now, we see that now when we're doing IVF, we see it in the embryos, okay? We can test the embryos now. So we make embryos, and then we can do pre-implantation genetic testing, and we see, here you see it, that at around 30, about 30% of the embryos are aneuploid. The aneuploidy is coming from the egg, okay, an abnormality of the egg. The sperm, okay, when men with normal sperm counts, only 1% of the sperm are aneuploid. 1% of the sperm are aneuploid. Okay, 99% of the sperm are normal, euploid. Okay, because the man is making sperm every 2-3 weeks. You have new sperm. Women have the eggs, you know, for years, 35 years. So here you see it at age 35, we're seeing now closer to 40% embryo aneuploidy, and at age 40, we're seeing more like 65% aneuploidy, and then at age 42, we're seeing 80% aneuploidy. And this was done with 15,000 human embryos, and this study has been repeated, so it's clear. And what are the common aneuploidies? And we all know Down syndrome, and yes, chromosome 21 is affected with gains and then monosomies, trisomies and monosomies. Chromosome 22 is highly affected, 19, 18, 16, 15, 14, 13, and all of the chromosomes are affected by this aneuploidy process. What's going on? So here you see it. Now people are starting to look at meiosis, aneuploidy. What's causing this problem? Well, you can see here the chromosomes, they're lined up, okay, in the metaphase. These are young eggs up here on the top, and you can see the chromosomes are fairly lined up, and you can see the spindles are red. The spindle is red. They're aligned, okay? These are young eggs. Over here are the older eggs. Now you see the spindles unaligned, disorganized, and the chromosomes unaligned, disorganized. So it's not clear yet what the cause of this aneuploidy is, but people are getting closer. So what do we do? So here, let's see. I just got a few more minutes. But what to do? Okay. And so here, this is my take here. For women who are under 35, okay, complete your family by age 35. That's ideally, right? That's an ideal situation, but don't start your family at 35. Complete the family at age 35. And with for the medical professionals, of course, and all professionals are really affected by this. But that basically solves a lot of the problem. If you can't do that, then consider an egg freeze cycle. If you're over 35, okay, you can see the reproductive endocrinologist. Consider assisted reproduction, in intrauterine insemination, IVF, pre-implantation genetic testing. This is all available. We're doing it all the time. If you're 45, yes, you can still have a family, but this is the age that we recommend donor eggs. Okay. Now just a little to finish here. Egg freeze. Okay, egg freeze. What is the current status of egg freeze? Okay, so this is the American Society for Reproductive Medicine guideline. This is what they are recommending, and this is what we follow. Fertility and Sterility, published in 2013. In patients with infertility with due to chemotherapy or other gonatotoxic therapies, oocyte preservation is recommended for patients with cancer. The committee declined to recommend oocyte cryopreservation for the sole purpose of circumventing reproductive aging in healthy women. In other words, so just elective egg freeze based on insufficient safety and efficacy data. So that's what they said in 2013. And now, this is the recent one, 2018. Planned oocyte cryopreservation, that's what it's being called now, is an emerging but ethically permissible procedure. Okay, so this is where this basically started a lot of the donor of the egg freeze cases. More egg freeze is occurring now in the infertility clinics. Okay, but they still said here there's still uncertainty regarding efficacy and long-term effects. Okay, so more data is coming out on that. This one just came out of NYU. They're one of the leaders in the field, 2021. 231 patients were retrieved. Now it's kind of interesting, the mean age of the first egg freeze. So when should women freeze? Well, the younger the better. However, there's a broad range. In this study out of New York City, the average age was 38. So we can freeze at age 38. The range was 23 to 45. 3,250 eggs were retrieved. Okay, when was the first egg thaw? When did that occur? The mean age was 43. Okay, what about the eggs? Do they survive? Do they survive an egg freeze? Do eggs survive? Yes, they do. 74% of the eggs survived. You know, the freezing process now is vitrification, and it's an excellent procedure. We're doing that in the embryology lab now. Okay, the mean fertility rate for these fertilization rate. Do the frozen eggs fertilize? Yes, they do. 70% of them fertilize. What about the eggs? Are they does freezing cause aneuploidy? Okay, does freezing cause aneuploidy? Well, here they found an aneuploidy rate of 74%. Okay, quite high. But as you can tell, the average age was higher. Okay. Now this whole aneuploidy thing, the more as more experience is gained, it's turning out that the aneuploidy rate seems to be a little higher than people actually thought. Okay. Now out of 36 embryo transfers, there was 18 live births. Okay, and these were euploid embryos that were transferred. So the live birth rate was 50%, which is good. That's good. Now, is it safe? Okay, this article came out in 2009. They had at the same place, NYU. They had 900 oocyte preserve babies, and with none of them born with congenital anomalies. So there was no increase in congenital anomalies. That was 2009. And to bring you up to date, there's been 5,000 babies now born from egg freeze. And it looks like the congenital malformation rate is the same baseline compared to normal eggs. Okay. In 2018, 13,000 women banked their eggs in the United States. The average cost is $10,000 per egg freeze cycle, and that's average across the United States, and it's similar here at UMass. And our goal when we do this is to freeze 10 eggs per cycle. Okay, thank you.
All right, thank you so much to our panelists, Dr. Arroyo, that was wonderful as well. I'm going to open up the chat real quick. I do have one comment that's here that I want to start off with. I'll make it a little bit of a comment and question. I feel like we're getting really good at letting our patients know that they need to take care of them and do regular medical checks. Meanwhile, in most of the cases, our family planning does not include fertility checks early on in reproductive life. Culturally, we only go to a fertility doctor if there's a problem, not as a preventive consultation. And I think that stems on both sides of this, is that, you know, we're really good at kind of taking care of problems and not prevention. Do you have any kind of thoughts on preventive? Some of your slides actually address this. This question came earlier, but some of the questions about freezing eggs, and that does kind of speak to prevention of infertility. But any other thoughts on that from any of our panelists?
I think Dr. Leftwich said the first step really is this dialogue and education, because I'm thinking back to my training years, I don't think anybody ever talks about this. So I don't know what we can do. Maybe Dr. Arroyo can speak to that, of fertility preservation aside from oocyte preservation. But I think just starting to make this the norm, introducing it into the curriculum of medical schools, I think is also important, because once we talk about it and recognize it, it will no longer be one of those issues that we see in hindsight and say, if only I had known. And it's just amazing that we know so little, that we do so little for each other to talk about this, knowing the rates are so high. We did a course at the American Urological Association a couple weeks ago on this similar topic, and one of the gynecologists there mentioned that there was a research study in the gynecology literature about OBGYN residents, and that this is incredible, compared to other trainees, OBGYN residents had equal levels of knowledge about fertility rates and the rate of fertility decline. So even those of us who in our minds should be, becoming experts on this, we don't educate each other about this. So if our OBGYN resident colleagues are not aware of these fertility facts, then certainly the rest of us aren't either. And we could do a lot to educate each other. And our job as, I think, faculty and mentors is to really start discussing this and pushing it as an agenda item on medical school curricula.
Yeah, I think that's right.
And Michaela Tobin responded also that you could ask your primary care physician to test AMH just to know kind of your reserve early on. And that's a valid point. Thank you for that, Michaela. I think we're kind of wrapping up. Any other questions? I don't see any other in the chat, but I'm going to give people just a couple extra minutes to put anything that they have, but then otherwise I'll thank our panelists for their time.
It was our pleasure. Thank you for having us.
Thank you.
Yeah, thank you so much for having us.
And again, thanks to everyone who came out tonight to listen to our panelists and to spend your evening with us. Lynda, you want to do the wrap up?
Yes, I will.
That might be it.
Thank you. This has been really very, very interesting. And I'm pleased to see that they have this newer thing like advanced maternal age, because in my area, I'm a pediatrician, and When I had my children, which was over 40 years ago, I was an elderly primate.
Oh, Lynda, I think we're called geriatric now. I think they've replaced that, right, Dr.
Yes, it's a little, that's a little more academic than elderly. Yeah.
From the OB side, that is a billing code and not an but yes, both of those are actually billable codes right now. Isn't that terrible?
Oh my goodness.
Oh, it's awful.
When I heard that, I said, what? Anyhow, so I learned a lot in this, and this was really very, very interesting. I thank Heidi very much for bringing this to our attention, and also to bring us these wonderful speakers that we had tonight. So thank you to Drs. Yates, Van Horn, and Arroyo. I really found this so interesting. So if you go to the Worcester District Medical Society website, you can look at Worcester Medicine that did an article on infertility, and a lot of this information, not all, but a lot of this information is there. And this will be up on the website. So if you wanted to look further into the references that were given, into the data that was given, that should be there for your perusal. I would think in a few days when they can get this together and get it back on the website. So thank you, everybody.